Our first witness tonight is Ms. Dr. Jessica Schorr Saxe. Dr. Jessica Saxe has been a longtime advocate for affordable health care, for universal access for all people. She, for a long time, ran a clinic here in the city of Charlotte, North Carolina, that helped people gain access to reduced costs and free health care who were in need. Dr. Saxe, let's hear your testimony tonight.
Thank you very much. And it's a real honor to be with this group to talk about what's such an important topic. And as Reverend Sadler just reminded you, the pandemic has had a disproportionate effect on Black and Brown communities, so that, for instance, Black people are more than twice as likely to die as white people. And just looking at Charlotte, if you take out the deaths that are associated with nursing homes, 3 out of 4 of the deaths in Charlotte are in people of color, which of course is disproportionate to where they are in the population. So we've heard a lot about that since the pandemic, but what many people don't, I think, realize is that that occurs on a background in which there were already really severe health inequities. And I prefer to use the word inequities rather than disparities, because inequities puts in your mind that there's something unjust and unfair about them. Blacks were already more likely to die in our culture, had lower life expectancies, and that's the background that this is happening on. Now, as Reverend Sadler alluded, some of the reasons that Blacks are disproportionately affected have to do with things like being on frontline jobs, living in housing that's more crowded, which means if you live in crowded housing, you can't follow orders to quarantine if you're told to. They're more exposed to environmental hazards, which put them more at risk, and of course have problems with access to health care. And then there's also the issue of underlying conditions, which at the beginning of the pandemic, as he said, we kept hearing about people who got sick had underlying conditions. Now, if you look at a list of those underlying conditions, what you'll see is that many of them are more common in Black people. For instance, chronic kidney disease, heart disease, obesity, and diabetes. And that raises the question of why. Why do more Black people have these conditions? One of the most important things I want to tell you tonight is that there is nothing wrong with Black bodies. That is not why there are more underlying conditions. It actually relates to some of the other things that are in fact related to racism in our society. For instance, Blacks are less likely to have health insurance, and they're more likely to lack access to health care. And one of the things that does is it not only means that they may be more susceptible to chronic conditions, but if they have something like diabetes, it may be more poorly controlled, which makes them more susceptible. When I was in practice, I had lots of diabetics in my practice. And if they were able to keep their visits and if they were able to afford their medications, we could usually get their blood sugars under control. But if people can't afford to go to the doctor, or they don't have transportation to go to the doctor, then those chronic conditions are more likely to be poorly controlled, and that puts them at higher risk. And then there are the other things like poverty and low wealth, lack of education, that also are risk factors for poor outcomes from COVID. In addition to that, besides the indirect ways that racism works on this, there are also direct effects of racism. And one of them is that it's been well documented that Blacks get poorer treatment in our healthcare system. They're less likely to have pain treated. They're less likely to have access to procedures that are needed. And not surprisingly, they're more likely to avoid healthcare. And there's even a more direct way that racism affects this, which is that chronic stress, including the stress of racism, causes an increase in stress hormones and an increase in chronic inflammation, which then can lead to other diseases. And then there's another factor that in this day and age we have to talk about. People talk about the fact that we have twin pandemics now. We have the virus of COVID, and we also have the virus of police violence against Black people. And people have talked as if those are two separate pandemics, but what I actually want to tell you is that they're related. So one factor in this is incarceration. We know that Black people are many times more likely to be incarcerated than white people, 5 times more likely, I think. And people who are incarcerated are 4 times as likely to get COVID. So that's one risk. And then there's the police violence itself. We're well aware that violence has a bad effect on the victims of violence. Obviously, they get hurt or if they get killed, but it also has an effect on the people around them, bystanders and family members. People in those situations are more likely to have certain conditions like mental health conditions like PTSD and depression. They're also more likely to have some physical conditions, which include asthma and migraines and so on. And people who live in surveilled neighborhoods are more likely to be obese and have high blood pressure. Well, all of those are some of the things that in fact are risks for COVID. So that's where we've been, that's where we are, that's where we've been. I just want to say a couple of words, and I hope there's some more questions about where we need to go, what would make a difference. Our organization, Healthcare Justice North Carolina, is an organization that supports Medicare for All. And Medicare for All would be one really important factor in relieving racial inequities, because it would mean that everyone would have access to quality healthcare. But even though I think that's important, that's clearly not the only thing. In the short run, we need to expand Medicaid. And what I'm happy to see is that the current COVID relief bill includes something that maybe will be so attractive, it'll even attract our state to expanding Medicaid, which would help hundreds of thousands of people in North Carolina. We need to address all the other things that affect health, like education and housing, because those are important not only in their own right, but also because they affect health. And we need to address racism as well, which is something that you all are talking about here. What I think that now we have a moment. I think that the world, the country has become aware of what some of these racial inequities are in health, that the pandemic has made people aware. I think we, as you all are doing, is we have to grasp this moment, hold on onto it, and help the country move forward. Thank you.
Thank you so much, Dr. Saxe. It's significant to hear you talk about this. As you've been talking tonight, it sounds like your comments are suggesting that the concerns that we see here in Charlotte about, I can't remember the term you use, inequity between Black and white patients. These are not just issues that attend here in Charlotte, North Carolina, but these are larger issues. So the concerns that we see in Charlotte, are they actually national concerns?
Oh, absolutely. There are similar concerns everywhere.
So what do we need to do, not just at a local level, besides the notion of changing the way that we deliver healthcare? Because I could still see that some of the underlying issues that we talk about, i.e., doctors don't tend to spend as much time with African-American patients, that the attention that they give to their treatment plans is often more generic and not as tailored. Some of these concerns might persist. How do we begin to address those concerns, even under a transformed system?
So there are many things that we need to do. And so one thing that we could do is that we need to make the healthcare workforce, physicians and everyone else, nurses and everyone else in it, look more like our country. It has been shown, this is very painful for me to say because I'm a white physician who took care of mainly of African-American patients, but it's been shown that there are actually better outcomes. Black people have better outcomes when they see African-American doctors. So it would behoove us to have more African-American doctors in our workforce, in particular, more African-American males. Which we're farther behind than African-American females. So that's one part of it. But the other part of it that I would say, again, as you know, as a physician, I want to feel that I'm giving adequate care to everyone. And I think that we have to train everybody to be able to take care of everybody and to not only treat them courteously, but to really respect and embrace other cultures and learn something about them.
Amen. Thank you for that. So that notion of cultural competency comes back as something that we really have to attend to as we deal with these issues.
And just another word about that, which is a term that I heard, as I've been looking into this, is cultural humility. And majority culture people need to have some humility about our culture and realize that we don't just want expect everybody to join in it and come along, but that we really need to understand the best of everyone's culture.
Thank you. Thank you for that. As we look at these concerns sort of in the larger world, one of the things I'm concerned about is that our elected officials, the leaders of our healthcare organizations, they may not know that these inequities exist in the larger community. How do we help them to become aware of it? And then how do we help them to begin to develop policies to address these concerns?
Well, I actually think from what I've been watching, I've been very, I'm sure I didn't learn anything. It's hard for me to remember medical school. It was so long ago. But I'm sure that none of this was addressed when I was in medical school. But as I talk to people who are coming through and I hear what's going on in other organizations, I think that there is more and more awareness in organizations about health inequities and about the fact that we need to address them and that people need to educate themselves and people in training about things like implicit bias. Everybody says I'm not a racist, but people need to understand the ways in which they are racist, even though they think they're not, because they've learned that's a bad word. And the other thing I think for a group like this is as I said before, I think that we have to hold on to this moment and not let it escape, and hold people's feet to the fire now to make sure that we make change.
Amen. Thank you so very much for your testimony tonight. We definitely have heard what you have said, that we need to pay attention to these inequities that exist in our system, that they continue to disparately impact people, and that we really do need to have a more just system that provides equal access to everyone. Thank you so much, Dr. Saxe, for your work and for your testimony tonight.
Thank you for this opportunity.